So when you look at the next unit here, we look at we're going to do it from the regions of the body. We're going to do head, jaw, the neck, the thoracic spine, the lumbar spine, and then we're going to revisit pelvis again and the integration. So we'll be looking at hip one more time, but more from pelvis and superior to that. But so we have TMJ, that jaw, the mandible, then we have and then in the thoracic spine, we also have, so we have mastication, so chewing in the mouth, and we have ventilation, so chest cage expansion. I also have those integrated into the thoracic spine a little bit. I'll have its own little separate video for respiration. I already have it posted in the module or in the Unit 4 folder. And then the last thing we have to do is the posture and gait. And like I was saying, I have posture integrated into each of those aforementioned areas. So like talking about how posture is affected. And then what we're going to do for gait, there'll be more of a capstone looking at, because gait's really dynamic posture and standing posture, static posture. And the integration between the upper extremity and lower extremity that happens through the trunk and spine is basically how gait mechanics occur. So we'll introduce gait from that component. So really the bulk of the material is going to be the videos I post this week. The head and neck, jaw, trunk and spine, and the pelvis is integrated in that. So that will be the bulk, and that will cover about 60 to 70, maybe 80% of this whole unit. And then we'll have a little bit on the ventilation muscles, a little bit on the mastication, and then a little bit on gait, more so bringing together some things that I highlighted in the previous lectures. And I think your book, that's not the book. Hold on one second. So your book starts at chapter 14, and then we go through the neck and trunk. And so your book takes chapter 15 and combines it together. I did chapter 14, and I split it up a little bit. So it's going to be one long unit till the end of the semester, and you'll just kind of follow suit in each of these divisions, like TMJ with head and neck, and then I did neck with the TMJ, and then I have trunk and lumbar spine separate, and then I integrated respiratory system into that. It's just better to kind of put it all together, and then I have the pelvic girdle, which we already talked about in the previous unit here. I'm doing again, just in terms of its superior aspect of the base of the spine, right? Because the pelvis is really integrated to the sacrum through the SI joint. So it's not going to quite follow the order of your book, but all the content will be there. And what I would recommend is just kind of read through the chapters. Like the jaw is pretty straightforward. I mean, when we look at the jaw, like I shared, is really only like maybe 5 or 6 muscles that are involved in closing, 5 or 6 muscles that are down. And then really all you have to kind of figure out is the different, I can actually pull up the lecture and I can show you. I'll give you a preview of the, so just kind of understanding the depression and elevation and how it has this anterior translation and looking at the muscles that are responsible for that. And so you have this arthrokinematics that you can kind of look at and see how there's that anterior glide. And in this video, and then in your book, and then probably also on Blackboard, I'm not seeing what I'm looking for. You'll have this is what you'll have to know because it's not muscles that you normally are used to, is kind of knowing the muscle actions. And so looking at the closing versus the opening. And so I have these slides here where it looks at like the masseter and the temporalis as an elevator. You also have your medial pterygoid. And that's really all you got to take from this chapter is the joint motion of the jaw and the muscle involvement. There's not a lot of structure. It's really when you look at the structure of here, there's not a lot of connective tissue that we need to know. You have that joint there. You have the mandible. You have the temporalis, the zygomatic arch. And then you have a little bit of that crazy moving disc thing with the structure there. Kind of have this articular, where is it at? This here, you have this disc that's part of the joint cavity. It's like a moving vertebra, right? It kind of moves with the mouth when it opens up. So as the jaw opens up, that disc gets distorted and kind of follows the path. Let me see where I have a video of it, not a video, but an image. Here we go. So just kind of understanding the lateral pterygoid's involvement in that, and that's it. So it's just those couple things. And so that chapter is basically done. You still go through the chapter, do the review, but there's more, a little bit more detail. But in terms of big picture concept, there's not a lot going on. Where the bulk of the material is going to be in chapter 15, just because there's so much going on in the spine, and so much of what you're going to be doing is going to be dealing with like spinal issues. And then, of course, that it fills or it supports our concept of the posture, because this is really what you're looking at is the foundation there. And so when you go through the video, well, it's going to look at the cervical spine by itself, the head and neck, because it's kind of its own unique beast. The cervical spine is above the shoulder girdle, and the shoulder girdle and the pelvic girdle, those are what's used to generate alternative or reciprocal forces for gait and ambulation. And it's between the shoulder girdle and the pelvic girdle that is really the definition of the core. So when we look at the musculature for spinal stabilization, and we're going to actually look more at the muscles of respiration, and then we're going to look at the muscles that are between the shoulder girdle and the pelvic girdle. And so what the head does, the head has slightly different function because it's really not load bearing. It is load bearing in terms of the head, but it's not force generation, and it's more just kind of the steering wheel. Whereas the shoulder girdle, so the thoracic spine and the lumbar spine are your force generators through the pelvic girdle. So I have that by itself, and it looks through, but the way your chapter is, it's going to investigate the differences between the cervical, thoracic, and lumbar spine. And as you would expect, the cervical vertebra are not meant for load because only dealing with the size of the head. And in the lumbar spine, you can actually see here, appreciate how thicker those vertebra are because of the load and the load-bearing responsibilities that go through it. Your overall motions here of flexion, extension, and lateral flexion and rotation, that's happening collectively through all 12 of the thoracic spine, 7 of the cervical, and 5 of the lumbar. So you're getting through the entire aspect, and you'll get more range of motion at certain areas than you will at others, and the video kind of goes through and kind of teases that out. So this is a good comparative between the cervical vertebra and the thoracic and lumbar vertebra. And what makes the thoracic vertebra unique is that out of the 3 regions, you have the cervical and lumbar spine that share the same curve. Thoracic spine has its own unique curve, and it also has these additional facets because it articulates with the ribs. So the ribs are a mobile joint, and they need to move because that's how respiration occurs. And so when we look at like rib function, or we look at thoracic function, the ribs are really nothing more than an extension of the thoracic spine. And so they have these extra facet joints. And the cervical spine has these 2 oddball vertebra. It has the atlas and axis. So there's your axis, and it's called an axis because it has this bone protruding up that acts as a pivot point like an axis. And then you have the atlas, which is a play on Greek mythology of Atlas holding the weight of the world on its shoulders. Well, in this case, this holds the weight of the head on it. And where these little grooves right here, these condyloid surfaces, that's where the space of the skull, or the occiput bone, that's what articulates there at the atlas. So you have the C0, C1, C2 for this cervical region of the neck. This shape, this structure is vastly different than this here. And even this guy is different. But it kind of has a little bit more of a body, where this one has no body, right? It kind of has this open ring. And that's to allow this thing to come up through it to allow for that cervical rotation. About 40 to 50% of all your head motion, so turn your head to your right, to your left, happens between this bone and this bone, the axial atlantal joint. And then the rest of the range of motion, because you have about 80 degrees of cervical flexion, and you get about half of that. The other 40 degrees comes from the remainder of these cervical vertebrae. Your thoracic spine, because of the facet joint, the way that this joint's stacked, I've got a picture of a facet joint here. So the bone-on-bone interaction between the vertebra does not happen here at the vertebral body. So right here would be your vertebral disc. That's more of a cushioning and a buffering mechanism to allow motion to occur. Your actual joint motion is happening here at the facet joint, where this joint interacts with the facet of the joint below it. And the orientation of these facets this is what determines the available range of motion that you have at that joint. So when you look at the cervical spine here, the facet joints, they articulate at like 45 degrees. And so you get flexion, extension, lateral flexion, and rotation pretty well through all three planes because of that orientation. When you look at the thoracic spine, they're almost like this. And so they block you from going into extension, but they can kind of go over and slide into flexion, but they allow mostly lateral flexion from left to right. And then the lumbar vertebra, instead of being like this, they're kind of like this. So they they prevent you from going into lateral flexion or rotation, but they allow you to do mostly the flexion and extension. So kind of understanding that facet joint, and then goes into a little bit more detail from that, but you can read right here. But I think what I just said in that 60 seconds is sufficient. This is right here. This is kind of a cool image. It shows you the orientation of those facets to kind of show you the type of plane of motion that you can have. So here you'd see that you can maybe go forward and back more sagittal plane, whereas here is going to be more frontal plane alignment, allowing more lateral bending. And then the cervical spine has the 45 degree, which is not depicted here, but that allows you to do all the motion. Now that I'm doing this, I think I did talk about cervical spine in the previous aspect, because I know we talked about some of the musculature. So what I'll do is we'll skip down to the thoracic spine. Actually, I think that's it. It ends the thoracic spine. Well, let's quickly talk about the lumbar spine, and then we'll go into the muscles, and then that will be it for today. So I like this image here because it shows the sacrum, which is the base of the spine, wedged between both halves of the pelvis. And so this makes that pelvic girdle, and where the pelvis goes, the sacrum goes. And if the sacrum moves, the lumbar spine moves. And so you really can't have a spinal discussion without talking about pelvic mobility. Now, the pelvis doesn't move on its own. The axis of the pelvis rotation is actually at the hip joint. So this is why we revisit the hip again. And that if you go through a posterior anterior pelvic tilt, the axis of rotation is right here through the femoral acetabular joint. And so when you go through this anterior or posterior pelvic tilt, you're doing it based on the availability of hip flexion or extension. Same thing with the lateral movement too. Like if you do hip abduction, like lateral flexion, that is only happening because of the adduction that's happening at the hip. So the pelvis really doesn't move. There's no joint of the pelvis. It's a combination of the lumbar sacral joint, so the relationship between S1 and L1, L5 and S1, and the motion at the hip. And between these two joints, that's how you get your anterior posterior pelvic tilt and your lateral movements, and how we really control the good or bad posture. But I think I talked about the neck muscles already, and so let's go down to the trunk muscles. This muscle right here, the rectus abdominis, is the most popular abdominal muscle, and that's what everyone focuses on for their training. And it's not really, it's a functional tendon is what it is. It's more of a mobile aspect. The big workhorse musculature of the abdominal are these guys here, the external oblique and internal oblique. And the reason why is that they just have huge moment arms, huge muscle mass, and they are primed for torque producing. And so your external internal oblique are your primary torque producers. And if you can kind of appreciate where they attach right down here at the linea alba, that's where the rectus abdominis attaches. And the rectus abdominis has these intra-abdominal bands. And each of these divisions of the muscle, it does go the entire length, but they're innervated by different segments. So you have your own neural intervention going to rectus 1, 2, 3, and 4. And why the rectus abdominis exists is that you're able to get yourself in all of these different positions. The abdominal muscles contract so to allow the obliques to have a solid surface to contract off of. So the rectus abdominis is really a support mechanism for the obliques. If you take a look at a posterior view, you'd have the spine and you'd have all these interspinal segments to stabilize, and you have a lot of structural stability. You don't have a lot of anterior stability. And so that's what the rectus abdominis does, is it's more of a functional. So if I'm like twisted this way and bending down a little bit, the rectus abdominis can tighten up so that the internal and external oblique have a solid surface to contract off of to generate force. This gets all the attention because that's indicative of being lean and looking good and whatever. But in terms of a functional aspect, it is a support. It's really important. I don't want to say it's not important, but in terms of, it's more of a functional tendon for stabilization than it is your obliques are your primary. And so the obliques aren't just for rotation or lateral flexion. They're involved in sitting up, so trunk flexion and eccentric trunk extension. Your transverse abdominis is your deepest abdominal muscle, and this muscle is part of the spinal stabilization mechanism. And what in the one video that I posted already in terms of muscles respiration, it talks about the inner unit versus the outer unit. And the inner unit, outer unit are the musculatures of the abdominal cavity. And so the inner unit is the diaphragm, which we get introduced when we talk about respiration, the pelvic floor musculature, the multifidus, which we'll talk about in this unit because it's the deepest back muscle, and then the transverse abdominis, which is the deepest abdominal muscle. And these four muscles together make like a capsule within your abdominal contents. And it's that abdominal, that capsule that creates abdominal pressure that prevents gravity from collapsing on into the spine. And so when that contracts part of the transverse abdominis, it's like pressurizing a water bottle, and it does not allow anything to collapse down. So the spine takes some of the loads, but the abdominal and the abdominal contents help to buffer and offload that. And that's done by the transverse abdominis. But these are your four abdominal muscles, your rectus, your both external, internal oblique, and your transverse, and this makes up your abdominal wall. This is just one fraction of the core. Everyone always wants to talk about the core. This makes up just one part of that. When we flip around to the back, we get the two muscle groups, the erector spinae group, which are made up by the ilicostalis, longissimus, and spinalis. And then you have the transverse spinalis group, which are these guys here. And the big difference between these two muscle groups is they're basically the same functional. I'm sorry, not, but they're same in terms of their anatomical layout. They are on the posterior aspect. They all do spinal extension some point. They do lateral flexion. Where they differ is in their transverse plane motion. These muscles, let me pull up my, these muscles have a lateral origin and a medial insertion. So they kind of come up at an angle. And if you were to see all these together, they would look like a Christmas tree, right? Just all kind of pyramided out. The erector spinae, they have a medial origin and they have a lateral insertion. So they come out like a V. So they come out this way. And it's a subtle difference, but it doesn't change function for the frontal plane, and it does not change function for the sagittal plane. What it changes function for is transverse plane. And why that is that when you look at this medial to lateral orientation, when that muscle shortens, it's going to try to take its, let me draw different. Let me just draw an arrow here. If this muscle here tries to shorten, right, and you got all these muscles on this side, you got all these muscles on this side. What it's going to try to do, it's going to try to take its insertion, it's going to try to move it over itself. Because that's how, here you got your lengthen, and if it's going to shorten, it's going to kind of come back in this direction. And so the erector spinae do ipsilateral rotation. So the right erector spinae muscles are going to do right trunk rotation. And the opposite is true for these. If you're here, it's going to try to take this and pull it back this way. And these attach on the spinous process and it kind of creates a lever. So when it takes this and pulls back this way, it's moving the back of the vertebra to the left. It does contralateral rotation. So that's the big difference based on the orientation between these two muscles. It's the rotation component. Now these are big stabilizers. They cross just a couple joints at a time. There's a bunch of muscles here like the rotatories and the semispinalis and multifidus. And you kind of see here, let me just get this organized. You see these numbers here, 5+, 1, 2 to 4. That's how many vertebra that the muscles are spanning. So all of these have this Christmas tree orientation where the semispinalis, they go from like C1 all the way down to C6, C2 all the way down to C7, C3 down to T1, right, all the way down. Whereas multifidus spans like 2 to 4, so it'll go from like T5 to T2 or T2 to C6, right, kind of does that spanning. And then your rotatories, they span one vertebra at a time. But they all basically do the same thing in terms of that rotation, right? So that's the big difference between the erector spinae and the transverse spinalis group. When you look at bilateral, they do trunk extension function. When you look at unilateral, they'll do lateral flexion and rotation. And the rotation component is also coupled by the muscles up here of the abdominal. And so when you look at rectus abdominis, it does trunk flexion and trunk flexion only. When you look at the obliques, because of this, you can kind of see the angle of the lines here. You can see that these, that's what, come here. You can see the fiber orientation like this for the external oblique, and the internal oblique kind of comes up like this. And just while we're at it here, the fiber orientation for the transverse abdominis is transverse or horizontal. So you can see that if this guy contracts, it's going to be like a constrictor. It's going to be like a girdle around the torso, kind of constricting everything in. When these guys contract, this pulls this end and pulls it around this direction, and so it does trunk rotation. Same thing here. This pulls this around and does trunk rotation. And actually, I have these arrows drawn backwards, so it's actually going to do this. So what the internal oblique will do is it will contract, and it will do lateral flexion if it's unilateral, but it'll also kind of pull you down into that position. So it's going to pull like the left shoulder across the body there. So it's going to do ipsilateral rotation. So right side internal oblique is going to do right trunk rotation. An external oblique, it comes up and around and grabs, and it's going to do opposite side rotation. And the way, if this image was superimposed, I have one in the lecture, but you have internal oblique with fibers coming this way, and you have external oblique with fibers coming this way. So the overall resultant of those two movements together, because what's happening is this is pulling down, so it's pulling the rib cage this way. So my left external oblique is pulling my rib cage this way, while at the same time down here, my right internal oblique is pulling forward. It's going to create this big moment arm down in that direction there. So when you look at like trunk flexion, you get bilateral external internal oblique that are doing trunk flexion. If you look at lateral flexion, you're going to look at the same side external, same side internal to bend in that direction. And when you look at rotation, you get this quadrant-like situation where you get internal oblique on the right side, external oblique on the left side. That's producing same side or right side rotation. And so it follows the course of the internal oblique. So that's the big takeaway from the trunk musculature is the rectus spinae group in terms of their function and the abdominal groups in terms of their function. So then the other muscle that doesn't belong in either of these, that can't make up its mind if it's a back muscle or a abdominal muscle, is the Quadratus Lumborum. Now it's technically a back muscle, but if we had a skeleton, you can appreciate how like straight up in the middle this muscle is. And so sometimes it's an abdominal muscle because it's kind of closer to the abdominal, and sometimes it's a back muscle, but it's like right in the center. So really what it does really well, let's have an anterior view of it. If you look at it from an anterior view, it's a powerful lateral flexor. So it kind of just pulls you to the side. So there's no question that does lateral flexion. But the Quadratus Lumborum is really just kind of a, if you're looking at doing a hip hike, this is the muscle that's involved in that. But it's considered a back muscle, but it's kind of right in the middle. It's just, it can be a back on some days, depending upon how much extension you have or flexion you have. And it can be a flexor or extensor based on how much flexion or extension you have. So that's the other muscle that's there. Besides that, we have a lot of the more complex musculature is in the neck, which we talked about last week. But you can kind of see the different layers here: external oblique, external, outside, external, internal oblique, internal. Hopefully there's an image of the abdominal wall. Here's your rectus spinae group. You can see all of it on the lateral side. On the left side is the rectus spinae. Right side is the transverse spinalis group. Again, the only difference here in terms of function is that this does ipsilateral rotation, so same side. This does contralateral rotation. So what you see here, left erector spinae and right multifidus, is all, if both of these groups, if both of these guys contracted together, these groups, you would get left trunk rotation and extension. I think that's it for the introduction to the unit. So type of questions that will be on the exam, we'll be looking at like these type of things where it's asking like if you pick up a suitcase, like I know for sure there's going to be a suitcase question. That's like just some kind of lateral flexion. Now how it's asking like what muscles, see how he's doing right lateral flexion, left cervical flexion to keep his eyes level with the horizon. What's happening at the hip, right? That hip abduction. So looking at this whole analysis and looking at eccentric control the muscles on the left side as you pick this up, and concentric if you, or I'm sorry, put it down. So asking some questions based on this functional aspect. Cool. Any questions at all? So like I said, I have the lectures done. I just got to record them. That should take a day, and I'll have those posted for you next week. So we have next week to go over the, I think next week would be a good week to like take this week and just kind of relax, recuperate, maybe read through the chapters a little bit. Next week, jump into chapter 15. I think it's chapter 15, whatever the trunk and spine, chapter 15, the neck and trunk. Kind of review the temperament, the TMJ, neck and trunk. If you watch those videos in the respiratory system, you have quite a bit of it done already, and I have it reintegrated into the thoracic spine, so get a review of that. And then really what's left is the down here, which would be the posture and gait. And like I said, posture is it's incorporated. You can see it's all like thoracic spine, and so we kind of have to have the conversation when we learn about the spine, when we look at the posture. Just now we're looking at what are we actually looking for, but it's pretty straightforward. But we'll do that the last week of, so now let's see. So yeah, we'll kind of look at that as we come into our exam, which will be this week here. So it'll be more of like a capstone. So you studying for posture will be kind of you reviewing the material here. But we're right on schedule.